I would want volunteers. I just want someone to help us identify read the question and identify what the slide is. Then we can discuss further. So we can have a volunteer now. Any volunteers?
Hi, good evening.
Yeah, good evening.
It's the question says there's a 2-week-old first of a set of male twins born at estimated gestational age of 30 weeks, but this is an X-ray, right?
Yes, please. Okay. So what do you think? The question is giving you some history to the X-ray. So this is the X-ray of a 2-week-old first of a male twin born at age of 30 weeks. What do you think is the diagnosis from just looking at the X-ray? Or what are the things the pathology is going through your mind for this particular story has been painted? Hello?
Hello, yes, I'm with you. I'm looking at the X-ray. But the question on my mind is, why are they taking an X-ray of a pregnant woman?
Sorry, the diagnosis in my mind is...
No, the first question in my mind is, why would an X-ray of a pregnant woman be taken?
Okay, this is pediatric.
Okay.
This X-ray for a 2-week-old male twin. This is the first twin. Yes. So this twin had an X-ray taken, and the twin was born at an age of 30 weeks. Do you understand now?
Okay, yes, I understand now.
So what diagnosis is coming to your mind? So that we open up.
Maybe an obstruction in the intestine, or
Obstruction there?
I won't say in the intestines.
Okay. Why do you think that? What can you think that is making you think of an obstruction?
Because of the black spot.
Sorry,
Hello, can you hear me?
Yes, you said because of the...
Because from the X-rays, I can see there's a blockage or something, because the black spot, something is not passing, or something is not fully developed there.
Okay, I wish I had a pointer. Okay, thank you. So who just spoke? Your name?
Dr. Abdul.
Okay, Abdul. All right. I want to see if I have a pointer, but I don't think Telegram has that. Okay, so we'll just go ahead. I wish I had a pointer. All right. So the way to look at this question, there are going to be questions with answer under it, but I think I'll just go ahead and just discuss, and then we'll answer the questions together. So they present an X-ray to you, and then the question is 2-week-old, first of a set of male twins born at estimated gestational age of 30 weeks. First thing is, a twin baby is born at 37 completed weeks. Do we agree?
Yes.
So, do we now agree with me that this baby is a preterm baby? The owner of this X-ray is a preterm baby?
Yes.
Yes. So this baby is a preterm baby because the baby was born at 30 weeks gestation as opposed to 37 completed weeks, right? So that's the first cue. So this X-ray is from a preterm baby. Now this X-ray is from a twin. One of the twins, who is 2 weeks old, is having this X-ray, right? Are we with me?
Yes.
Yeah.
Great. Now, the first thing that will come to your mind is, okay, what are the conditions that are common to preterm babies, whether male or female? The sex there is just additional information. The key thing is the baby is a preterm baby and he's 2 weeks old, right? So what are the conditions that can occur in a preterm baby that would warrant us doing an X-ray? He thought of an obstruction. Who thinks otherwise? Who thinks it's something else? Who has a different opinion?
I think it's respiratory distress.
Okay.
That
What's your name, doctor? Hello.
Yeah, hello ma. Yeah, this is Emily.
All right. Thank you. But I think look closely. What section of the body do you think this X-ray is covering? Because if you say respiratory distress occurs where? What part of the body?
In the lungs.
Exactly. So what part of the body do you think we can see?
Yeah, I can see. It's the abdomen.
Sorry? Exactly. So you think it's okay if I disagree with you, right?
Yes.
So now let me redirect us. What other conditions do we think can occur in a preterm baby at 2 weeks of age in the abdomen that will warrant us taking an abdominal X-ray, because it's an X-ray. It's a plain abdominal X-ray. Who has another differing opinion?
Interception.
Okay. Who said interception? Sorry?
Necrotizing.
Who said that? Who said necrotizing enterocolitis? Your name is Judith. All right. Okay. Somebody whispered intussusception, but I disagree with you. Why? Because in intussusception, if you remember, if you've read it very well, everything in pediatrics has an age, right? That has an age. And that's why this question is not carrying a 2-year-old boy. This question is carrying a 2-week-old, e.g. a 30 weeks. So I'll agree more with necrotizing enterocolitis as opposed to intestinal obstruction and intussusception. I don't agree intussusception. Of course, I say never say never in medicine, but common things would occur commonly, right? Common things will occur commonly. And I don't think this exam is going to be one that will be bringing on common things. It's going to be common things. So once they give you a picture, think of the commonest thing that can look like what you are seeing, okay? So I agree more with necrotizing enterocolitis. Have we all, at least, who hasn't heard about necrotizing enterocolitis? Who hasn't heard about necrotizing enterocolitis? I should presume we all have, right? Great. So intussusception, for the person who said intussusception, is in an older age group. It commonly occurs at, I think, more than 6 months of age. So it doesn't come up here at all. Intestinal obstruction, yes, can occur, but in a preterm baby, what will really cause an obstruction that will present this late? An obstruction will present earlier because you have started feeding that baby early. And so within the first week, something should be happening. Okay? Not to say that necrotizing and enterocolitis cannot occur earlier, But like I said, common things occur commonly. And then for intestinal obstruction, Dr. the person who said, I can't remember your name, but I don't think you will see what you are seeing. So I want you to browse now that we're still talking, just browse intestinal obstruction X-ray and look at what you are going to see. Obstruction, I think you would see, I think you might see, Dr. Isaac, I stand to be corrected. I think for intestinal obstruction, you should see you should see bubbles.
Okay, for intestinal obstruction, in the supine X-ray, it may actually appear like this. However, like we said, for a 2 weeks old child, may likely have intestinal obstruction. However, if they have intestinal obstruction, commonly it usually will be something that we physically see in physical examination, like omphalocele, gastrochysis, which is very or in some rare instances, intestinal atresia. But those ones will not come within this period. So 2 weeks of life at each of 30 weeks, likely necrotizing enterocolitis and not intestinal obstruction. Well, necrotizing enterocolitis in a way can also cause intestinal obstruction when there's necrosis because of what we call the non-obstructive intestinal obstruction. It is likely necrotizing enterocolitis that they are expecting the candidate to mention. Thank you.
All right, thank you very much, Dr. Isaac. So he talked about intestinal atresia. Intestinal atresia, the picture we would see, depending on where the atresia is or the obstruction is, if it's in the duodenum, we would see a double bubble sign. That is what the X-ray is going to look like. So we can browse. I don't have that picture readily that I've shown us so that we see how different that is from this one. Just browse double bubble sign, duodenal atresia. Then we have the triple bubble sign for jejunal atresia. And that is the pictures you are going to see. That is what they are going to look like. So you count 1, 2, you can see 2, what looks like air under the diaphragm, but they call it bubble on the radiology, the X-ray. So that if you see 2 of it, it's likely duodenal. If you see 3 of it, it is likely jejunal. If you're going to post pictures like that, it's going to be that clear. It's not going to be ambiguous. Necrotizing enterocolitis, what you are seeing on this X-ray, I wish I had a pointer, I don't, is what we call pneumatosis intestinalis. Write these things down, you browse it and check it, read more on it. I'm just pointing us to the, I just want to, trigger us to read more. So the X-ray of necrotizing enterocolitis has what we call pneumatosis intestinalis. What is pneumatosis? Air between the wall of the intestine, right? Air between the walls of the intestine, which would usually appear like this. Now, necrotizing enterocolitis can become obstructed and maybe perforated. In fact, the complication we're scared of is perforation. When there is a perforation, you will see what is air under the diaphragm. Air under the diaphragm. Okay, which would look like those bubbles I'm talking about. But when it is intestinal or jejunal, if you count the bubbles and it's a preterm baby and you are seeing 2 and is within the age for the atresias, usually the first week of life, and they'll paint some other pictures for you that will tell you this thing is likely not a perforated neck, it is duodenal atresia and jejunal atresia. I want to pause here to ask for questions. Do we at this point have any questions? Any place you want me to repeat what I've just said again? Any clarity you want so that before we move further?
Yeah, could you say something about necrotizing?
Should I what?
Could you say something about it? Like you explain.
No, I've not even gone into the explanation. I'm talking of how to identify the diagnosis from the picture that is placed before you. And I've tried to explain why this should be necrotizing enterocolitis and not intestinal atresia. So at this point, do we have any confusions before we go into necrotizing enterocolitis proper? Does anybody want me to say what I just said again about the differentials, the way the pictures may come, the x-rays may come, and how we may be able to differentiate it? Did we all get it, or do you want me to clarify something? If no, then we move ahead. Does anyone want anything to be clarified?
No, thank you, doctor.
All right. Thank you. So we're going to, so that this is necrotizing, we all follow. Necrotizing enterocolitis, pneumatosis intestinalis. Great. So now, what is necrotizing enterocolitis? I asked earlier if there was anybody who hadn't heard about it. I presume nobody answered, so I presume we've all heard about it. So this is going to be a reminder. Now, necrotizing enterocolitis is a medical or medical stroke surgical emergency. It's a pathology that occurs predominantly in preterm babies. Preterm babies, but can occur in term babies in some conditions. Right? So that is what necrotizing enterocolitis. And just like the name, when you hear the name, necrotizing, there's necrosis, enterocolitis, that has to do with the bowels, right? So something is causing these bowels to be inflamed and then to have necrosis. So I told us that majorly it occurs in preterm babies, reason being that their bowels are immature and cannot, handle the kind of stress that maybe a term baby or other people would handle. So this is very peculiar to preterm. But like I said, it can occur in term babies. In term babies, you see it in some conditions. I don't think they are going to bore you with that detail, but just know that it can occur in term babies. Now, what is the etiology? What causes this thing? What causes this condition in preterm? Oh, sorry, I don't think you can see my screen. Can we see my screen now? It just blanked out a bit. So what causes this condition? Now, in the pathogenesis, right, there are three things that need to occur for the setting of, to make it ripe for necrotizing enterocolitis to occur. Three factors. Take note. One, you must have initiated feeding. So enteral feeding is one. And that is why this baby, has been feeding for 2 weeks. So the picture fits perfectly. This baby has been feeding. They likely have started feeding this baby. And then, now the baby has this X-ray. Number two, bacterial translocation. So somehow bacteria has gotten into the system and directly into the intestinal walls. So first, enteral feeding. 2, bacterial translocation. 3, ischemia. For some reasons, blood supply to that particular place is compromised. So you have ischemia setting the stage for necrosis. Now, we have these 3 things occurring before we can say this. The setting is ripe for necrotizing enterocolitis. Now, for the organisms that can cause necrotizing enterocolitis, we have bacteria and some viruses. So the bacteria we have, we have Klebsiella, E. coli, Clostridium perfringens, and I think there's one more I cannot remember. We have viruses, but just know that these are the bacteria that have been found to commonly cause it. But of course, once we have septicemia, anything causing sepsis, it could be staph, it could be anything. Once it gets to the wall of the intestine, I talked about bacterial translocation, enteral feeding, and then ischemia. So we have that, and then we have this condition. How will this baby look like? what are the presentations this baby is going to have? We're just seeing an X-ray, but before we go to the X-ray, we've taken history and we've examined. So what is this history going to look like? One, they're going to tell you first is a preterm baby, right? Preterm baby. 2, feeding has been commenced. Feeding has been commenced. 3, there should be abdominal distension. There should be abdominal distension. So the stomach will swell up, right? There will be abdominal distension. Sometimes the surface will look, okay, I've entered examination now. But okay, history, abdominal swelling. Then 4, there will be signs of, unclear signs usually, of what we call constitutional symptoms. Just unclear signs of general ill health. What do I mean? Temperature instability. Babies, as opposed to older children, cannot say, okay, you can't say, oh, they will always have fever before you know something is wrong. It can be hypothermia and it can be hyperthermia. Okay, so temperature can be high or can be really low. That's one. The baby will just not be active. Okay, baby will not be active. Then there may be other things following that. There may be hypoglycemia. You check the random is either low or high. Then the other ways the baby may present is vomiting. The baby will start vomiting, what we call feed intolerance. You are feeding babies vomiting. Or if you're doing a gavage feeding, what I mean by gavage feeding is you pass an NG tube. For those on them on admission, we sometimes feed with an orogastric. So we pass a tube directly into the stomach and feed. That's something else. I don't want to go into detail. So you feed them, and then you see that next time you're supposed to feed them, there's still the feed you left there 2 hours ago is still in the stomach. It has not been digested. That is called feed intolerance, together with vomiting. Now, this vomiting may become blood-stained. I talked about ischemia, blood-stained, so necrosis. Sometimes the intestine will start sloughing off, and then you begin to get blood. Sometimes, so that may be a presenting feature. Or the baby will start passing blood-stained stool or frank bloody stool. So these are some of the signs that this baby will have, amongst others. I trust we are going to read the rest. How do we investigate this baby? Bringing us to this our question now. Now, to diagnose necrotizing enterocolitis, you need a plain abdominal X-ray that is showing you this picture of intestinal pneumatosis intestinalis. Somehow air has got into the wall of the intestine. You can see that, you may see that, or if the neck has progressed really bad, you may see a frank perforation with air under the diaphragm. Okay, but this is what you are likely to see for this age. You understand? So that's that. You want to do first a plain abdominal X-ray. Next, you want to do other investigations, your usual full blood count, and in your full blood count, you want to see or let me stay on the X-ray bit. So aside X-ray, aside the pneumatosis intestinalis you see, I told us for complications like perforation, you see air under the diaphragm. Now there's a concept called portal venous gas. Once a baby has these symptoms I'm talking about, and you're suspecting neck, and you do this X-ray, and you see anything that looks like air in the portal vein, it's a bad prognostic sign. It's telling you this pneumatosis, this necrotizing enterocolitis has a poor prognosis, right? It has really progressed. So we've talked about pneumatosis intestinalis in cases of perforation under the diaphragm, and then portal venous gas. You see them on when you do your radiology. So you do that supportive investigations, your full blood count. You understand? We call them baseline, but there's a reason why we do every test. So full blood count, when you do your full blood count, it should be in keeping with features suggestive of sepsis. How do I mean? Reading your indices of full blood count. please pay close attention, because this question may help you answer something I say, may help you answer some other question you may see in the exam. So for full blood count, how do I know that this full blood count is suggestive of sepsis? First of all, we want to look at the total WBC count, the total white cell count. Generally, for older children, it falls between 4,000 to 11,000. That is the normal range for us to have when you do your full blood count. If you see anything elevated higher than 11,000, it's telling you that white cells are being recruited to likely fight an infection. So what we call leukocytosis, right? Please, if at any point you've lost me, you can stop me so I go over what I'm saying again. Now, in a preterm baby, usually their own white cell count is higher than the general pediatric case. So usually you can even see as a normal 20 to between 25, 30,000. So now I do this baby's full blood count and I see something like 35,000 or even low. Even low, leukopenia is all suggestive of sepsis. So it's either there's an elaboration of the white cell count or it is reduced. Now, what is the next thing I can look at in my full blood count that's telling me, there's infection? PCV. If there's an infection, of course, in sepsis, the bacteria will start to attacking it's attacking everywhere. It's attacking the red cells, breaking them down. So our PCV may be reduced, right? Are we with me or I've lost us? Hello?
So you're saying that in sepsis, WBC will increase.
Increase or decrease?
Okay.
PCV low, platelets decreased, likely decreased. Now, when you look at your differentials, we talk about neutrophils, lymphocytes, eosinophils. The usual pattern for a baby differs with their age. We can go and check it. I don't want to confuse us. So, the baby that is just born, the pattern looks a particular way. If I see a reversal of that pattern, then there's sepsis. A 2-week-old baby, the pattern should look differently. If I see a reversal of that pattern, then it's suggestive of sepsis, and so on and so forth. In an older child, what a full blood count differential pattern suggestive of sepsis will look like would be, if it is a bacterial infection, we have more of neutrophils, so we have neutrophilia. I'm sure we must have come across this at some point in our training. Once you see neutrophilia, generally speaking, bacterial infection. Once you see lymphocytosis, generally speaking, you are talking about a viral infection, except for M. tuberculosis. M. tuberculosis is the only bacteria that will give you a lymphocytosis. Are we with me? Hello? Anybody
Exactly here.
All right, then we can go ahead. We do our EUCR. It's going to be deranged. There may be some form of respiratory issue. Like I told you, constitutional symptoms. These baby may start having problems breathing. Okay, so EUCR will be deranged. Sodium, your electrolytes may be deranged. And then you do a blood culture. You are going to get the offending organism in a lot of the cases if the culture was properly done. So now I'm going to post a question. Okay, investigations. How do we treat? So I mentioned something. I said it is a medical emergency. stroke surgical when it has perforated. So it could be medical or surgical emergency, right? But the treatment, there's no definitive treatment. There is no definitive treatment. So we give supportive care, right? So if the baby is not breathing fine, you want to supplement, you give oxygen and everything that the baby needs to breathe fine. Okay, you want to support the respiration. If there is electrolyte derangement, you want to correct it. If there's hypernatremia, hypo or hyperkalemia, metabolic acidosis, you want to correct it. If you get signs, if you culture an organism, you give antibiotics for it, right? If the blood is low, you would give blood, right? If the platelet is low, you would give platelet concentrate, or you give fresh whole blood, whatever you want to do. You want to support in any way the baby needs support while you stop feeding. You need to stop feeding this baby. And so when you stop feeding the baby, you have to, of course, give adequate fluid. So you have to place an IV line and recalculate what this baby needs in places where we can give parenteral nutrition total. You start that while you rest the gut. We call it resting the gut. So you stop feeding, you give your antibiotics, you give all the supportive care, oxygen, blood, whatever the baby needs, you give while you wait for the condition to settle down. Now, you may go over to considering surgery when you see perforation. So one of the signs of perforation, well, the sign won't really be there. Maybe the abdominal distension will just keep getting worse. The abdominal will keep increasing. So you now do an X-ray, you see at that point you call in the surgeons, and then they want to go in to do to maybe dissect the particular place, or anastomose and all of that. So that is when you call in surgeon. Otherwise, you manage supportively. I'm going to post some questions now based on what we have just discussed so that you answer. Then we go from there. Okay. So, Dr. Abdul, I think you were the first person who spoke. Are you still here?
Yeah, I'm still here. I was a little bit ill, so that's why I can't speak. Like I was having sore throat.
Sorry, 1 minute. Sorry, Dr. Abdul still here?
I'm still with you.
Okay. Oh, sorry. I want to post the questions, right, so that you answer. Let's see if you have, if you've gotten it. All right. So I'm going to share again. I hope you can see. All right. So now that X-ray is for this question. So just go through the question. So you either answer true or false. Let's go. Can you see my screen?
It's difficult seeing it. Can you imagine?
Oh, you can't see it, right?
Hello?
Hello, can you see my screen?
Yeah, I can see it.
Oh, all right, great. So let's go so that we would conclude on it and maybe take one more slide before we call it a day. Based on what we've discussed, Dr. Abdul? Can we have someone else, please?
Hello.
Yes, please go ahead.
Yes. So for the first one, the commonest site is the distal ileum and distal colon. True. Umbilical catheterization is a risk factor. Oh, I don't know if I think it's true. Then the surgical management is definite. First, because you said unless there is perforation, if not, management should be supportive. Then for venous portal gas, whether it's a good prognosis, it's not a good prognosis according to what you taught us. Then histologic finding. I think it's true. The last one.
Doctor, what's your name?
Rhoda.
Okay, thank you so much, Dr. Rhoda. Thank you. I'm so glad, that you were listening. It's very encouraging. So I will take number 3, 4, because I actually talked about them. Then I didn't talk about the rest. So I'll just quickly brush on it, then we move. So thank you so much. Thank you. Very encouraging. So surgical management is definitive, is false. It's false because I said there is no definitive management. Management is supportive. So she's correct. Yes, we may need to go for surgery when there is complications, but even that one is not definitive because, in fact, when the surgeons come in, you hear from their own side or their own end the complications that usually goes with such a surgery, especially in a preterm baby. You understand? All right. So we just manage supportively. It's one of those conditions we rather prevent than you start thinking of curing. It is a very serious condition. So it is false. She's correct. Number 4, portal venous gas portends good prognosis. She's very correct. It's false. I said once you see gas in the portal vein, it's telling you that neck is bad. Right? Or you see air on that diaphragm for this age group, 2-week-old preterm baby, it tells you this baby may have perforated. Now let's go back to the first question. Commonest site is distal ileum and distal colon. Now, for most conditions in babies, most condition that occurs in the intestine in babies, most, if not all, the commonest site is that junction between the smallest colon, the small intestine, and the large intestine. So that is going to be what? Distal ileum and proximal colon. Did you get me, Dr. Rhoda?
Yes, ma'am.
Yeah? Did you get me?
Yes, I did.
Good. So it's going to be distal. So they talk about Meckel's diverticulum, intestinal obstruction, all the things that can happen in a baby, in a neonate. Most of those conditions, if you check them, you check the text, you are going to see that for those who mentioned it, the commonest site is distal ileum proximal colon. So that is what makes that a false. They said distal ileum, which is correct, but they now said distal colon. No, it is the junction between the two. That's where, I don't know why, but that is where they've cited as the commonest site for this condition, as with most of the other conditions. Now, number B, the next one. I somehow missed it when I was talking. Thank God for this question. It's very, very important. Umbilical catheterization is a huge risk factor. Huge risk factor. So for those of us who are going to come here to do a house job, you will notice if we have any baby with necrotizing enterocolitis and the baby is on the umbilical venous catheter, as we stop the feed, you will hear us say, remove the umbilical catheter. And then you see us generally shy away from passing a UVC for a baby that can have a line set. You understand? We just don't want it because of this particular issue. So Umbilical venous catheter is catheterization, the procedure itself, the vein, because you are introducing a foreign body. No matter how you want to observe that your aseptic procedure, you don't know. You may just introduce directly, and you are just putting it directly into the vein. It's going straight into the bloodstream, swimming right into the intestine. So it's a huge risk factor. So that particular question is true. Now I'm going to the last one. Histologic finding is liquefactive necrosis. No. They've done the it's coagulative histology. If you remember histology, is either liquefactive or coagulative. So when they found out when they did the histology of the intestine, it was coagulative necrosis. So do we have any question, or we move to the next and I think the last slide? Any questions, or we're good? Dr. Rhoda? Any other person, Dr. Abdul? Any clarity, or we move?
No question.
All right. So I'll post. I'll just share this one. So who can help us attempt